Actually, assalamu alaikum everyone. If you can hear me, just reply in the chat box. We're just going to wait for about 5 minutes and uske baad inshallah we'll start. I'll request the participants to please mute their mics ताकि lecture के दौरान फिर you don't have unnecessary background noise और आप लोग मुझे सुनने में समझने में कोई मुश्किल ना हो. Thank you. All right, I think we have about 81 participants. I think last time we had, mashallah, crowd of around about this much. So I think I'll start. Assalamu alaikum, everybody. Thank you all for joining in for this second webinar on what I hope, inshallah, will be a full series on oral and maxillofacial radiology. My name is Dr. Fahad Kiam, and I'm a maxillofacial surgeon myself, but I have a personal interest in radiology for various reasons. Number one, that it's a core component of maxillofacial surgery, as well as your general dental practice. But unfortunately, since we do not have maxillofacial radiologists or dental radiologists in Pakistan, so it's not a taught component at the undergraduate level, and it's more of an interest for someone to learn it themselves at a postgraduate level. So last week our webinar was basically on introduction to dental radiology, where we just basically talked about dental x-rays, the equipment used to produce dental x-rays, the different type of sensors that we have, and different type of films we have, etc., and the development of conventional x-rays. So today we're going to take that a step further. The basic reason for doing any x-ray is to find out any pathology, and you can only appreciate pathology once you know what is the normal anatomy over there. So a lot of times I have experienced it myself, and sometimes my students come up to me showing me an x-ray of a normal structure, but they tend to perceive it as a pathology because this is something they don't expect to find over there. So I think in order to appreciate pathology, you should first have an appreciation for the anatomy of that area. So today I'm going to be discussing what is the normal anatomy that you see on periapical x-rays, on bite wings, on occlusal x-rays, on an OPG, on a PA view, and on a Waters view, which is an occipito-mental projection. So these are basically the contents of the webinar today, and you might feel that I'm missing out on a few things over here, that I'm not talking about all possible x-rays that there are. I'm not going to be doing all possible x-rays because once you come into your professional life and your professional practice, you're going to find out that if you know even these x-rays well enough, this is good. This is good enough for you. For the reason that we don't order every type of an x-ray that there is. There are very limited x-rays that we order, and those which we can even do here in Pakistan or in KPK, if I'm being very specific. And since today I'm going to be basically talking about anatomy that you see on a plain x-ray, you will find out that for many indications we have now switched over to specialized x-rays like CT and CBCT. So inshallah, for those I'll be having dedicated sessions on for CT, CBCT, MRI, hopefully, inshallah. So for now, we're just going to be talking about these x-rays. So let's start off with the intraoral x-rays. In the intraoral x-rays, I'll basically be talking about maxillary anterior anatomy, maxillary posterior anatomy, mandibular anterior anatomy, and mandibular posterior anatomy. Okay. We have someone who has raised their hand. Yes. If you have any question, please put it in the chat box. I'll request once again participants to keep putting in their questions in the chat box. I'll try to answer them as soon as I get them. The reason being that the meeting will end automatically at 40 minutes and I will lose your questions if I do them in the end. So if you have any questions, please do put them up, and inshallah I'll try to answer them right away. All right. Was there something someone needed to ask? Because I saw a raised hand. I have disabled it now. I'm sorry, I didn't know who was doing it before. So I have removed the annotations. Okay. All right, thank you. Okay, let's go ahead. Now, this is an X-ray, periapical X-ray of your lower posterior teeth. Now, I'll try to make this interactive. There are numbered structures over here. If anybody can answer what those structures are along with their number, just put them up in the chat box, and we'll see if you're able to guess what is correct or not. There are numbered structures over here as well, and there are also structures where there are long and short arrows, and some are broken arrows. So if somebody can answer that in the chat box, that will be great. I'm not seeing any answers over here. Hang on. Number one is enamel, fantastic. Number two, periodontal ligament space. One enamel, two is dentine, very good. Three is your root cementum, excellent. Four is your pulp. Yes, what about this long broken arrow over here? What do you think this is? CEJ, excellent, that is your cemento-enamel junction. What about this small arrow over here? Excellent, that is your lamina dura. You see, this lamina dura is basically this sort of radiopaque line which is surrounding the periodontal ligament space. So this is your lamina dura. Obviously, the upper arrow is now your PDL space. And what about this? What about these three small arrows over here? It's not a filling. Yes, it is your dentino-enamel junction. If you can appreciate this, this portion is more radiopaque and this is relatively less radiopaque. So basically your enamel is more radiopaque than your dentine. So this is the junction between your dentine and your enamel. So very good. And no need to apologize. Look, we are all learning here. There's no such thing as a wrong answer. All right. So what matters is you try. And even if you're wrong, you still get to learn something. Okay, what about this small broken arrow over here? What do you think this is? Yes, this is the crest of your alveolar bone. All right. So this is what you typically see when you look at a periapical X-ray. And these were things just related to teeth. Now we're going to obviously discuss the bony anatomy and other structures present here as well. So let me just go down a bit. Okay, this is a bite wing X-ray. Okay, so bite wings X-rays, these are typically done when you need to scan for interproximal caries, or you have a patient who cannot localize a tooth on one side of your arch, and this is a rapid way of doing of confirming whether there are any interproximal caries or whatnot, because you can see almost up to 8 teeth in one X-ray. So bite wings are usually number one done for that. They're also done as part of assessing caries progression in patients. So if you're recalling a patient just to see if there is any caries progression or any new caries developing, so this is a rapid way of detecting caries. Instead of exposing the patient to potentially 3-4 periapical X-rays, you can just do one bite wing and that's it. It is also used for measuring interproximal bone loss. As you can see in this X-ray over here, you cannot appreciate the interproximal areas very nicely, but in this case, you can see them very clearly. You can see quite clearly black triangles present in almost all teeth. So it's also good for determining your periodontal bone loss and what is the present or the status of the interproximal bone. So again, we have similar annotations over here as well. One is your dentine, one is your enamel, 2 is your dentine, 3 is your cementum, 4 is your pulp. The small arrow over here, this is the crest of your alveolar bone. And this long arrow over here, this is your periodontal ligament space. This long arrow over here, which is broken, this is your dentine cemento-enamel junction. And this area over here is, you can see again, this is a little radiolucent as compared to the upper radiopaque layer. So this is dentine, enamel junction. All right. So a common question which was told to me by one of the participants to include, she herself is mashallah an ORE qualified dentist. She gave the, I believe, the MJDF exam, and she told me that you were supposed to know two things when it comes to these X-rays. First of all, is that how many X-rays are you supposed to do for a full mouth series? If you want to evaluate the full mouth of a patient, how many X-rays do you have to do? So is there anyone who can volunteer to answer that question? Yes, please just write it in the chat box. Gee, anybody? 16, 3, 18. Shakir has said 4 bite wings. Excellent. So you've got half of the question right. What about the rest? 16 periapicals, 14 bite wings, 20. Well, the number varies, but overall you have to do 14 X-rays. Of the 14 X-rays, you have to do about 4 bite wings, and the rest 10 are your periapicals. But again, this varies. Some people do more periapicals and they do less bite wings, but usually the number of bite wings stays fixed. The number of periapicals, it does vary. So that is one thing you need to do for an FMX series. This is what is an abbreviation for the full mouth series. That if you want to evaluate the full mouth, you'll have to do about 14 X-rays. In those X-rays, you have 4 bite wings and around about 10 periapicals. But it can vary. Sometimes they do more, sometimes they may do less. But it's not a hard and fast rule. Okay, so let's continue. Okay, for whenever this, we've already talked about the teeth, so now we're going to focus on bony anatomy or soft tissue anatomy, which is particular to that specific area. So when it comes to the maxillary anterior anatomy, you have 3 structures which you will need to appreciate. And if you can recognize those structures, you can recognize this as a maxillary anterior X-ray. The first is the presence of the median maxillary suture. The second is your nasopalatine canal. And the third is a Y line of NS. So let's see these in X-rays one by one. Okay, now this broken arrow over here, if you this is pointing towards this radiolucent line. Can everybody see this radiolucent line? This is your median maxillary suture, and this you will be able to appreciate in your patients till they're about 15 to 19 years old, and that is when the suture starts to close. So okay, we are approaching our first time limit, which is odd. Okay, no problem. Anyhow, so this is the median maxillary suture, and you will be able to appreciate this in children and all those patients who may lie between 15 to 19 or below 15 to 19, because after that the suture closes. So if after that if you can still appreciate the suture in patients, it may signify maybe some sort of a syndrome, or it may signify trauma to this area, which has caused the fracture of the maxilla along its pre-existing suture line. Can anybody tell me what this small arrow is pointing at? Yes, it is a supernumerary tooth basically, and it is present between your central incisors on both sides. So this we will call a mesiodens. All right. Any supernumerary tooth which is present between your central incisor, that is called a mesiodens. If you have a supernumerary which is present outside the arch, meaning it is distal to your upper or lower third molars, that is called a distodens. And anything which is between other teeth other than your central incisors, that is usually called as a paradens. I'm seeing a comment over here from Dr. Hajra. G, what did you need me to repeat? Could you please tell me that? No, it's not the canal over here. This was basically pointing at the tooth. Dr. Hajra, you asked for something to be repeated. Yes, this is the suture. You see this line, radiolucent line between these two teeth. This is your median maxillary suture. So it stays like a suture, it stays like this radiolucent line till the patient is below 15. Between 15 to 19 years, this suture starts to calcify, then you cannot see it on an X-ray. Okay. The types of supernumerary, okay. There are basically three types of supernumeraries. The mesiodens is a supernumerary which is present between your central incisors. All right. Any supernumerary which is distal to your third molar is called a distodens. And any other supernumerary, if you have, let's suppose it's between your first and second premolars, that is called a paradens. Okay. I hope that's clear. So if we can move forward, just let me know in the chat box. All right. Fantastic. Okay, going ahead. Now, like I said, the second structure that you will see, this is your nasopalatine canal. Now, can you focus on these white arrows in this area? Can you see maybe one sort of corticated line going like this, another corticated line going over here, and then you see the same thing over here. So this is basically your nasopalatine canal. All right. So this basically carries your. Okay, we have another question over here. What is a paramolar? A paramolar is basically a distodens. You have different names for different pathologies. You know, like one name does not stay exclusive to a specific pathology. So paramolar is basically a sort of a distodens. Okay, so the nasopalatine canals, which you can see, this one coming from this side and this one coming from the other side. So these carry the nasopalatine nerve, and the nasopalatine nerve, this then exits in this area over here, and this is your incisive foramen or nasopalatine foramen. All right. The black areas, these are black arrows, these are signifying the presence of the nasopalatine foramen. Now, a question that I usually get asked is how will you differentiate if this is a pathology belonging to your central incisors uh, or is it simply just a foramen? So you have three criteria over here. One is that you measure the size of this foramen. If it is about 5 millimeters in diameter, it means it is a foramen. Anything larger than that, can be considered as a pathology, number one. Number two, if you have a nasopalatine cyst, so if you can see this foramen is not very well delineated. Its margins are not corticated or sclerotic. Like you can even see bone trabeculae in between this foramen. So whenever you see that the borders of this area are very sharply defined, so this can signify the presence of a cyst. That is the body's reaction of walling off a pathology. It wants to contain it, so it sort of walls it off. You can sort of call it a quarantine, if you will. Okay, so that is another criteria for that. And obviously, you'll have to look at the involved teeth. You can do vitality testing of the involved teeth. If they are non-vital, it can probably signify that there might be a pathology. It can be a radicular cyst or a periapical granuloma of those teeth. So it's not just that you have to depend on your x-rays, you'll have to use your clinical judgment here as well. All right. Okay, when the criteria, okay, I'll just repeat the criteria since we're running out of time, so I won't go on the next next slide. The criteria is that the diameter of your foramen, it has to be, it is round about 5 millimeter in diameter. Can you see the arrow that I'm moving? This area, if you measure this diameter, it should not be more than 5 millimeters. If it is more than 5 millimeters, it is signifying probably that there might be a cystic change going on over there. All right, number one. Number two, as you can see, this foramen area is not very well defined. All right, you can see even bony trabeculae in this area. So this signifies a foramen. Whenever you can see the sharp boundary of this foramen, it can signify that there may be a cystic change going on over here. Because whenever a pathology grows, the body's defense mechanism is to, first of all, wall it off, to sort of contain it within its area. So that results in the formation of extra bone on the periphery of that pathology. So that is what gives it a very well-defined corticated appearance. All right. So you don't see that appearance with the normal foramen, as you can see here. All right. And obviously, if it is a pathology, these bony trabeculae, you will not be able to see these as well. This will look like a uniform radiolucency. But in the case of foramen, you can see bone trabeculae in this area. So you know that this is probably a foramen and not something suspicious. All right. And still, if you're in doubt, you can do vitality testing of the teeth if you're suspecting a radicular cyst or a periapical granuloma. So if the teeth are non-vital, then obviously it may also confirm your suspicion that it is indeed maybe a pathology is in place over here, and it is not a nasopalatine cyst. It's not just the nasopalatine foramen. Okay, so is that clear? Okay. Okay, the meeting is about to end in less than a minute. So just if anybody else has any other questions, feel free to ask. Otherwise, when it finishes, just join the meeting again within a minute, and then we'll take it on from there.